Well, Michael, thanks very much for joining us. Another episode of Doctor's Journey, which is good. So really excited to have you on. To be honest, it's been a long time coming. So why don't you just go ahead and
Yeah,
introduce yourself, and then yeah, just tell us like what stage you're at as a doctor, and what you're currently doing, like what your role is, and yeah, we can go from there.
yeah. Thanks so much, Harry. So my name's Michael. I'm one of the current infectious disease registrars and in an advanced training position in infectious diseases. So this is my first year in advanced training. I've already completed internship and my completion of BPT, which is basic physician's training. I took a bit longer than the conventional 3 year. I did a few extra years of med regging to get a bit more experience up. And so I've done all those exams and now excited to be in infectious diseases training, which is a 3 year program. And I'm also trying to dual train in general medicine, which will add an additional 2 years to training.
So, I mean, first of all, because it's all like a recent thing, like a massive congrats. I know I've already given you a massive congrats already, but it's huge to like finally get through that first stage of passing all the written exams, and then like the sort of like long case, or those big essentially very daunting presentations where you see a lot of people carrying around their briefcases and presenting in front of all these panel members. It's a scary thing, right? So massive congratulations.
Oh, thanks so much, Harry. Yeah, it is a very big achievement to get this far. In terms of BPT, it's a 3 year minimum program through the training program. Starts with 2 years at resident level and then 1 year normally at a registrar level. And that's the year where you have to sit your examinations, both the written and the clinical exams. I passed the written first time round, but it took me 2 attempts at the clinical to get through. And happy with perseverance and a bit of extra practice year I've gotten through and now have this advanced training position. So fruits for the hard work over the years.
Yeah, exactly. Well, we might just like delve into that while we're on this topic, and then backtrack as we go. But talk us through, like, you do the BPT, you do your written exams, you pass them, and then you do like the in-person exams. And then after that, what sort of happens in terms of choosing like an advanced training position? Like, is it very much like you have to apply to that specific college, or that specific advanced training sort of stream, like infectious disease? Or is it like you preference it and you just get one? Or how does it sort of work?
Each of the specialty colleges have their own requirements and their own application. So some use a centralized match, some use like a CV. So I know that, for example, gastroenterology use like a point system to get people onto the program. For infectious diseases, it's a combination of curriculum vitae, references, um, and passing the clinical exams essentially. And then, if shortlisted, you do a panel interview with all the heads of units across the state. So they shortlist like 20 applicants or so to go through the interview. You can only get to that stage if you've passed both the written and the clinical exams. So that's the biggest hurdle into trying to apply to advanced training. I suggest the best way to be involved in trying to get onto a training program is to do your research early because you want to make sure that you have your CV sorted and that you have some references that are relevant to the discipline you're wishing to apply to. That way, you're ready for those applications. It's one where it's great success and really enjoyable once you finally pass the clinical exams, but then often there is a whole new host of steps and hurdles to go through, which is having to arrange meeting up with heads of units and preparing for high stakes interviews again. I'd been at the same health service for quite a few years, so it had been a long time since I'd done an interview. So I found that it was a bit daunting, but good to get back into the groove of practice again. But yeah, the steps of each college are a bit different. So yeah, it's good to be, if you have an idea early on in your physician training, it's good to research early the requirements of the specific college you're trying to apply for.
And is it like much different between the colleges? Like, I know you said the gastroenterology use like a points type system. Are many other sort of colleges like adopting that sort of mindset, or would you say like gastroenterology, like cardiology, like more competitive, have to go into that system now to sort of differentiate and select people, or is it just becoming more and more common? Like,
It's pretty common amongst most of the specialities to have like a checklist. Infectious diseases doesn't necessarily have a strict checklist. They value all elements of the application equally. Whereas I know that gastro is scoring points. I know that for a lot of training programs, a competitive candidate often has some research backing, whether that be like a case report write up or hardcore intense research like a small trial or other audits, which can really give yourself a leg up. There are other specialities within physician training, such as general medicine, that don't have a centralized match system, and you can apply directly to each individual health service to get an advanced training position. So, in that case, that would be more based on your desire to do that specific field of study and employment, and also trying to find the health service that best matches up with your values and, say, personality type. So, general medicine is one that's a bit more uh, not as structured in how they take their applicants, and is more a direct application to each of the health services you would want to apply in. So it does still vary, but I feel that a lot of the subspecialties are now pointing towards a point system, which does make things very competitive.
but it's still like you go through that sort of bottleneck altogether where you have to do your writtens and then your clinicals. Like, I mean, do you reckon it would ever be to the point where they just do something completely separate, or you reckon there's like just gonna always have to funnel through that sort of written clinical sort of process? Because it's different for like surgical, right? Like it's a complete different ball game, and you go their each individual specialties right up from the bat. And you don't sort of like worry about, say, like orthopedics if you want to do neurosurge. You just sort of like pass a general exam, sure, but I don't know. You sort of have to know a lot about like all these different other specialties with the written and the clinical.
Yeah. So to pass the written and clinical exams, you can't pigeonhole yourself into just studying for the career that you want to do. You have to have a real good breadth of knowledge, because the written exam in particular is a bit of a beast. I won't lie. Like, they ask things that even the most prepared candidate couldn't possibly get 100%. They sometimes pull some curveball questions. I remember a question about the specific cytochrome pathway, and it was like, that was a very obscure piece of information to recall. So, for me, I'm someone who really enjoys infectious diseases, but if you just studied for that with the goal of getting into infectious diseases, you actually wouldn't get in, because you still need to have your groundwork in cardiology, respiratory medicine, hematology, oncology. So all of those things definitely need to be studied for. I can't see it being like the surgical streams where there's just a general exam to pass, and then you really apply directly to the like anatomical discipline, whether that be like urology or orthopedics or plastics. The physician pathway, everyone has exactly the same um, curriculum essentially up until advanced training. And yeah, there's nothing you can try and avoid studying. It'll all come up.
Do you find then that, like, I don't know if this was the case for you, but you get to the end of it, you pass those exams, and do people apply for like multiple advanced training streams, or do you just sort of like settle on one after like thinking about it? Because I suppose like if most of them have similar requirements, I know maybe some more different than others, you could potentially apply for, say, infectious disease and also general medicine, and maybe I don't know the details, but like you could maybe do endocrine or something. I'm not sure.
Um, Yeah, generally, general medicine's a great speciality, and I'm going to try and dual train in general medicine too because it's very holistic and involves being a good holistic physician who can help balance, multiple complex comorbidities and complex patients. And often, a lot of people will dual train in one subspecialty plus general medicine, but it's not common to dual train in, say, infectious diseases and endocrinology or infectious diseases and cardiology. It tends to either be general medicine plus something else. In terms of being in BPT and then applying to do a specific training program or general medicine, not many candidates, to my knowledge, apply to multiple streams. Like I've never met anyone who's applied to both like cardiology, renal, respiratory with the hope of getting in. And generally, that relates to your ability to generate references throughout a medical career. It'd be very hard to be able to have references backing you into so many different medical specialities. So I haven't seen, not to say that it can't be done. Like there are a few doctors out there that have an interesting combination of dual training, but it's not particularly common. And in terms of research, when you put forward your application to a specialty college, they do tend to favor research within the discipline you're applying to. So if you've done a case report on, um, a bacterial infection, say for infectious diseases, but then you apply to cardiology, they might not rate that study very high. They probably want to hear your case report on Takotsubo cardiomyopathy or something, a little bit more relevant to that specialty.
Is there like, I mean, I know lots of surgical specialties have a bit of like a limit to how many times you can apply. Is it the same sort of thing with advanced training specialties? Like you get three cracks at infectious disease, and if you're not successful after three tries, then you can never apply again. Because I know it's like that for specialties.
So for physicians training, there's 3 attempts at both the written and clinical exam. I'm not sure if that's changed, but that was certainly the case when I went through training. For advanced training applications, the college has no rules about a maximum number of attempts. So if you build up your curriculum vitae and experience as references, there's no reason why someone who's gone through a different training program could not then reapply in the future. Not to say that they would be successful, because I suspect that when you apply, you probably have a similar examiner panel assessing you. So they may remember you actually from previous years. But there's also an opportunity then for growth. They might remember you and see that gee, their interview performance is much better this time, and gee, they've really worked hard on their CV. So for those with determination, I'm sure it is possible. You just have to put in a lot of work.
Mm, fair enough. Fair enough. So I guess backtracking again. So you've now been accepted to infectious disease, which is awesome. You did the clinical. You had two shots at that, and then you passed your written first time over. I mean, at that stage, you're sort of like doing like gen med regging, and then also like alternating between regging and different specialties as well. And then before that, you're doing like resident years. Like, I mean, how do you sort of cope with it all? Just like working and studying at the same time. It's pretty taxing. I'm not sure if you took much time off or what was your sort of strategy with it all.
Look, I always made sure that I like to keep in contact with my friends. And then I also wanted to make sure that I kept in contact with my interests, one of them being football or Australian rules football. For all the supporters out there, I go for the Kangaroos, which is a unfortunate, miserable existence. But what can you do? You can't. Once you pick a team, you can't really change teams. So what was difficult about that is that you come to work and it's stressful, and then you go to the football on the weekends and you lose more hair and it's more stressful. But it's still important to keep those interests up, because if you're just studying all the time, burnout is a real possibility. But if you're still keeping up with friends and keeping happy, and those things are important. Trivia nights, Harry. I know we've gone a few times. Like that can be something that's good. keep the mind fresh and have a dinner with mates. So you've got to keep those things up. Of course, there's the time to knuckle down and study. I suggest having a good group of people that you can study with who you trust. So to form a study group, I reckon in the BPT 2 years, probably the time to start thinking about that. Try and pick some friends and colleagues from work who you think that you can study with. Do some questions from study banks each week. That's a good way to prepare. You mentioned, Harry, about how to manage like being a med reg and things and studying. That's very difficult. For the written exam, a lot of studies does happen at home after hours, but for the clinical exam in particular, what's difficult is trying to balance your work responsibilities, but also being able to peel off a ward round to see a patient who might have an interesting sign that you may not hear very often that could come up in the exam. Example would be like a pulsatile liver, mitral stenosis, or spider nevi if it was a gastro case, something that you might not see every day. And, making sure that you're trying to maximize your learning opportunities, but never compromising the safety and care of your patients. So that's a balance that has to come through. Um, I think because I'd done a couple of extra years of BPT and regging, I found that balance was okay. But yeah, always focus on patients as well.
Mhm. Yeah, it's a tricky balance, I guess, as you first like put in the deep end because you do your BPT one as like a PGY two, and then your BPT two as a PGY three, and then often that's when you first start like doing regging, and you're like, well, I've got my exams coming up. I don't even know how to be a reg, let alone a medical registrar, and you're just like constantly freaking out. Like it's a massive like go on the deep end like it's probably not a bad thing to have a couple of extra years as like a med reg, just you know, sort of soaking up more time and experience, getting comfortable with stuff, so that when you needed to go deep into, say, I don't know, some random myopathy or whatever condition you need to, like the cytokines or something, you can actually delve deep because you've got like the basic framework of like med regging and how it works and the routine down pat. So I don't know, maybe more people should do like a couple extra years. I don't know.
Yeah, if you're not in a rush to go through training, like an extra year or two as a med reg, I know people are keen to get through, but it doesn't make a big difference over the lifespan of a doctor's career. We're one of the industries that end up working for quite a long period of our lives, and um, there's still doctors who practice well into their late 60s and 70s, and I expect that will continue, this century. So I don't think that it's too much of an issue if your friends are telling you that you need to get through right now through training. I think you just pause, reflect, and be mindful that if you end up being a consultant for 37 years instead of 38 years, does it really have any material impact on your life? I would say no. So you should do it in the way that suits you and your personality and lifestyle as much as possible. And in the same vein, if you think that it takes a bit longer to prepare for written exams and you wanted to split BPT 1 or 2 years, I know that some health services offer like part-time contracts to through their residency years to progress a bit slower, and that's also a very good opportunity as well to see a few more specialities and get a bit more hands-on exposure. Um, Maximize time on the wards and also allow you to still balance social life, friends and family. So yeah, I'd suggest to everyone out there not to necessarily rush your way through training all the time. You'll catch up in the end.
That's an interesting point of view because I feel like in my mind, like I'm the opposite. I want to get into training as fast as I can and then, get through it. And then you get out the other end because it's more of like a question of security and like, you have like a certification of like what you're doing. And, you're not like wondering, well, can I do this or am I going to fail this or whatever. So it's more like certainty, which is less like I don't know what the Australian healthcare system for medical professionals like looks like. Like there's very much like you get through, And then you're like, well, you may actually not specialize. You actually need to do all this extra work to specialize. And it's probably a fault of the system more so. I don't know if it could change or what your thoughts on it are, because I think that's very much a stressful thing for a lot of people.
It is because then there sometimes becomes bottlenecks in career progression. I know now that internship has changed to a predominantly 2 year model, where the first year of residency and internship sort of blend into one. But it's not supposed to increase advanced training or basic physician training time in doing so. It just gets people a little bit more time to settle into the healthcare system. I guess both approaches of rushing or going promptly through training versus a slower rate is probably not, doesn't make much difference at the end when you look at your career. I think what's relevant is how it suits you and your journey through medicine and sort of your journey through life. You know, obviously it is good to get through and get to consultancy level speedily, but when you're 45 years old and you've been a consultant for 10 years and you're the person at the desk next to you has been doing it for 11 or 12 years, it doesn't really matter in the end. You both have both the same level, and it's no one's going to remember that you took an extra year and black label you for that. It's not a no problem at all. So find the program and pathway that suits you is what I would suggest.
I think that's not a bad thing. It'd be interesting if you say you always knew that, say you pass your written, pass your clinical, that you were going to get matched into, say, infectious disease. Then it would be less stressful. It's the same way as like if someone's trying to get into like ENT and they matched into it. They just need to get through these hurdles. But at the end of the day, if they get through, they know they're going to get into that specialty. The certainty of that could take a weight off people's shoulders, I guess. And it's not more like a race to consultancy and as many years as consultant as you can, but more so just, oh, this is what I'm going to do. So I'm just going to get really good at it. Changing the focus, I reckon, would be a bit of an interesting one you know, to see how that would work in the future.
Yeah, well, we'll see. That's a very good point, particularly through surgical training. And sometimes in surgical training, too, the positions are a bit more competitive. Not to say that physicians not competitive, like there's still a lot of competition for advanced training places, but some of the surgical specialities like nose and throat ophthalmology, there's only sometimes a few spots nationwide. So I can appreciate if you knew all along that you wanted to be a ocular surgeon to try and get through as quick as possible. But I don't know what the future holds in terms of like how advanced training programs will work. I have to be one of these watch these space situations and see whether exam structures and things change.
Yeah, yeah, I reckon. I reckon. And I guess going back even further, when you finish internship and you're sort of towards the end of internship and you're thinking about going down this physician's training pathway, you're not sure what sort of area you want to pigeonhole yourself into. Getting into BPT, I mean, you don't really need to apply, right? You sort of just, I guess you do apply, but lots of people finish internship and go do BPT at the same hospital service that they're at. So it's very much just a preference, and then you sort of start doing it, right? Like it's not like a big selection criteria. There's no exam to get onto BPT one. You just sort of select to do it, and if the hospital says, then you just crack on and do it. Is that right?
Correct. All to get into BPT, you just need to apply for a BPT position at a hospital, and hospitals often advertise for different streams of jobs when you're past your internship or you're at a resident level, which is like PGY 2 or 3 level, and often they have physician streams, surgical streams, general streams. Some hospitals might have like critical care streams or psychiatry, mental health streams. There's no entrance exam to get into BPT. All you need to do is show a keen interest that you like physician rotations, and put that in your job application, and often you'll be successful in landing a BPT training job at a hospital. And often for familiarity, a lot of people do tend to commence their BPT at the hospital they interned in. But not to say that by any stretch that you wouldn't be able to get a position at other hospitals. This is one of the careers where people move around health services very often. In my case, in internship, I knew I wanted to do BPT training sort of by the middle of the year. So when job applications opened around August, September for the following year, I put all my eggs in that basket and just pretty much applied for a physician year and got it. So I think from experience and talking to other people, more often than not, if you get through internship, you'll generally get the year that you want, whether that be surgical, general, or physician's year, because there's quite a lot of positions in the health system for that. It's more if you want very unique years like rotations in ICU or radiology that it gets a bit more difficult.
Yeah, I think you just got to rock up to the interview with a stethoscope around your neck, and then they'll say, "Welcome to BPT."
Exactly. And be ready for the interesting physicianly question that I got, which was about something to do with like if I were a superhero, who would I be? So sometimes you get an interesting curveball question like that, like a medical superhero or fictional character. The answer is Sherlock Holmes, who has like an inquisitive mind, and that would be my suggestion. Someone who is a sleuth who likes to delve in deep, take the history, and find the clinical answers and solve the case. But I'm sure there's plenty of other good answers out there.
See, that's very interesting because that's the same question, the same interview question that I got asked when I was applying for a job at the cinemas. So the fact that they have the same question for a doctor position at a hospital and the cinemas is a good comparison. It shows how diverse that interview question is.
It works at so many levels. That question is the great discriminator. As there's the good answers, then there's the bad answers, like you want to be the Joker, you want to be Voldemort and things, and then you're going to struggle with your application to get into physician training. But if you just put together a decent fictional character that's not a super villain, you get a good chance of getting in. And then, of course, put in a bit of a good word about the sort of specialities you want to be training in and rotations you want to get. But focus on your superhero. That's my advice.
Exactly. And I guess, going back even further, like, how was your internship year? I know, like, how'd you find it? You said, like, halfway through it that you wanted to go down, like, physician training and everything. Like, what were the sort of rotations that you did, and, how'd you find them, and sort of know that you wanted to go down physician training?
I had a great intern year. I started on emergency, and then I did rotations in cardiology, general medicine, upper GI surgery, and geriatrics, which was a really good year. So three with cardiology, general medicine, and geriatrics. I got three medical rotations. Fortunately, I got the medical rotations a bit earlier in the year. I was able to get a good taste for them and knew that that's what I wanted to do. But I was also someone who always knew that I was never the surgical type. If those ever saw my woodwork from grade 7 and 8 high school, they would have known that they didn't want my hands cutting their pericardial layers and doing neurosurgery on their spines and the cerebral cortex. So I always knew that that wasn't going to be my jam. And so with doing the physician specialities, I really enjoyed their approach, and I just knew that's what I wanted to do. But it's still important to have the breadth of knowledge and make sure you're enjoying and focused in your surgical and emergency rotations, because you learn a lot of key life-saving skills. But yeah, I think I was fortunate that I had those rotations earlier in the year, which was able to reinforce and set in concrete that the physicianly pathway was what I intended to do.
Yeah, it's interesting. You like sample, different parts of the the health system, and then you, although you might not be interested in it, like I remember doing like a psychiatry rotation, and it was super good, super like eye opening. But if anything, it like shows you what you're not going to be suited to in the long term. You know, like you get as much as you can out of that specialty, but then it's like, oh, I know where that fits in the health service, and then you know what their role is, and you do need to rotate. Otherwise, if you just stay in one, spot, you just, I don't know, you lose your sense of awareness.
Yeah, yeah, definitely. And you need to be grounded and have knowledge about all specialities. And um, even as a physician, it's good to do surgical terms to get an idea of perioperative consultations and having an understanding of the procedures are going through, help surgeons manage complex patients who have medical comorbidities. And a lot of surgical met calls are actually for medical problems, like pulmonary edema, approach to fever, which may not always be surgical site infection. There could be other causes, and having that approach is important. Speaking to what you were saying a bit earlier, Harry, about how the rotation sometimes allows you to know what the ones you didn't enjoy as much strengthens what you'll enjoy in the future. When I was in emergency, I remember suturing this old man from a nursing home's eyelid after a fall, and he wasn't left with the cosmetic outcome wasn't looking spectacular, and the ED physician just pushed me out of the way to finish tying off the job, and it was like, that was my moment. Keep away from the stitches, and you know that straight away. So I tried.
I think to be honest, if anyone sort of perseveres with something, you will eventually get good at it. It's reps. But I mean, you just start off not so good, and then you become less good. Well, you become like less not good, and then you actually develop an okay level of standard, and then you get better and better. But I mean, it's good that you get pointed in the right direction through your rotations. I agree.
I like your growth mindset approach. Always growth mindset. I like that.
Did you find that there was someone like that sort of pulled you into infectious disease or the physician's training pathway? Or did you, I don't know, like I think mentorship is like honestly one of the most helpful things for junior doctors who are so overwhelmed by the system. They're just like, I just don't want to make a mistake, let alone specialize and get good at something. First starting out, that's what people are like, right?
For infectious diseases, I was always interested even at university level. I did studies and majors in microbiology and immunology. So it was always something that I really enjoyed and wanted to do. So it wasn't the rotation itself that like pulled me towards ID. It was something that I already knew that I loved parasites and bugs, and I should have worn it today, but I have a T-shirt that has a neutrophil and a worm on it. So, but yeah, I was always passionate in the geeky bug side of things. In terms of mentors, you meet a lot of mentors over the careers, over your career. And the ones I found as an intern that really stood with me actually was when I did my term on geriatric medicine. The geriatricians were some of the best physicians I ever saw, particularly in trying to balance competing interests in frail elderly patients and knowing when to investigate, when to stop investigating if it wasn't in the patient's best interests, how aggressive to medically manage someone, how, yeah, whether to escalate or withdraw treatment and all that balance, and got a good grasp of having to talk to families. So I think you find that you can find mentors in all different rotations and specialities. Even if you want to excel or specialize in one field, the mentors and people you work with in other specialities certainly help you on your journey through medicine and professional development and even personal development. I met so many great people along the way. Even some of the surgical consultants really enjoyed working with.
Yeah, and I don't think I could agree more, to be honest. Like the fact that it brings so much perspective. Getting ideas and the opinions from other people in other specialties who aren't really absorbed by this sort of you know I mean, I was going to say bubble, but all that comes to mind is a neutrophil net, and you know, you're you're absorbed by this whole environment that is very like bubbly, and you often can like have the simplest answer, but you just need someone else from outside your field to tell you what it is. So I don't know. I mean, as you said, like having mentors or relationships with people in the surgical field are just as good as having the same ones in the medical field and others as well. Emergency and ICU, it's all sort of collective relationships. I think that's super super important.
Yeah, so as a med reg, when it comes to having difficult discussions about appropriateness for intensive care and escalation to advanced life saving measures like CPR, intubation, renal replacement therapy, having been privy to discussions by intensivists is actually how I've often learned to approach these discussions. And even though, like, my long term goal is not to be a critical care physician, a lot of the discussions by being around those doctors has changed my phrasing of certain terms, knowing which words to avoid, knowing which words to use when talking to family, and even when talking to patients to allow them to make an informed decision. And a lot of good turns of phrases also came from my geriatric term. So it's valuable. I would make sure that, like, as you progress through training, you're not just pigeonholing yourself and looking to your own the speciality you want to do for mentors. Medicine's full of great doctors in all walks of life and all specialities, and try and take some things from every rotation you do and everyone you work with, good and bad.
100%. I think one of the other things that I don't know if you've found as well, but even just progressing in the same field, just by the nature of your becoming an intern to a resident to a registrar, you have different levels of conversations with different people. And as a registrar, so like what I've noticed is you actually explore a lot more relationships and conversations between people that you wouldn't have never interacted with as a resident. Even if you were rotating around to each different specialty, the fact that you're a registrar in one field means you speak directly to the consultant, you speak directly to the theatre staff, and you're organizing like equipment for the case, and you're talking to, I mean, bed managers. Sure, you can talk as a resident, but I mean, you talk to different people on different levels, and I think that seniority of the role exposes you to more parts of the health system. Almost you like unlock it, sort of like a video game, I guess.
Yeah, I think you're right, Harry. Uh, as an intern, often you escalate to your colleagues around you, which is normally a registrar, and then if you're referring to another specialty, you page the registrar, but you never talk to a consultant other than the home unit consultant. I don't think as an intern I ever remembered calling a surgical consultant or like a cardiologist directly. That just never happens. But once I progressed to registrar role, particularly say my role as infectious disease registrar, I'd say I'd be one of the most spoken to people in the hospital. Most days, nearly every speciality would page at least once. Sometimes registrars, HMOs, interns, I get paged by nurses about infection control issues. I've been paged by consultants wanting advice in clinics about hepatitis B management or whether someone needs to be worked up for tuberculosis, counseling staff who might have had a needle stick injury. So there's lots and lots of ways at the registrar level that I've had to have communication. And you do find that as you go through the career progression tree, you do end up having a lot more discussions with all all levels, all disciplines within a hospital setting. So I think you're absolutely right, Harry.
I feel like as well, you probably have, when you're like med regging and you're attending met calls and everything, you actually have a good conversation with the residents or the interns on the surgical teams. And because the regs is often, in clinic or theatre, and the residents are there on the wards, it's a really good chance for those, level of doctors to show what they know about both the medical issues for that patient and then also their surgical understanding. I don't know how you found like that sort of interaction, whether it's a met call or a code or something, and they're really put to the test, those like junior doctors. Yeah, I guess like what are your experiences with it, and like if you had any tips and tricks for those people?
Yeah, I've had a lot of experience with it because by doing a few extra registrar years, I was clinical lead a lot, which is something our health service has, which is a overnight registrar who sort of is the point of escalation for any issues. Any of the night interns or HMOs, nurses, and the bed manager communicate with you directly if there's any issues and sick patients that arise, and you attend all the met calls and all the code blues. And normally, as a med reg, you're generally managing medical met calls predominantly, but at night time, as a clinical lead, I was helping the surgical team manage all sorts of problems. What I my approach tended to be that I wanted the surgical HMO to come up with an sort of an interim or immediate plan based on like what they thought of the situation, and then offer guidance. I didn't want to be someone who told them exactly what to do straight up, because if you're just sort of barking your plan out, you don't allow professional development of those your peers essentially, because then in a year's time those people who you've just been barking instructions to will then become the barkers themselves, and if they've never been asked to lead that situation before, then they might get stuck in that situation. So it's always good to just fine tune their plan. Most doctors, if they are awarded a little bit of opportunity, actually come up with very good clinical decisions and come up with very good plans and only just need very minor finessing. Most of the time, I remember going to a lot of Met calls and my plan was just be like, yeah, that sounds like a good plan, and that's it. Like, and just offer them help to enact the plan. But a lot of it comes from the staff around you. It's good to not just it's good to not just turn and ask the most senior person what you want to do. It's good to try and always troubleshoot a plan. So I like to award the staff around me that opportunity. That was my approach to Met calls, even in the surgical realm. And when it was surgical things like the drain tube is dislodged, well, then I wasn't very helpful. I won't lie. If that was, yeah, I wouldn't know how to put it back in. But fortunately, that was very, very rare sort of reason for a Met call.
No, I think a lot of people are. Well, I mean, even me to an extent now. Everyone is, I guess, but they're very much like a Roomba. You know, they sort of like keep going in one direction, and then is veering a bit offline, and you sort of push them back in the direction that they should go in, and that's how it should be in like a safe sort of parameters, right? You should give them time to explore what their options are for that patient. Would they be better suited to option A or B or C? And then if they're sort of leaning to option D and you think, well, no, that's not a good option, then you push them back in the right direction.
Yeah, yeah. And then you cautiously change from IV fluids to frusemide, diuretics, and the balance, that their balance is a bit off or something, but just gently. But most of the time, you want what you don't want, say as a clinical lead responding to Met calls, is the reflex action being the the junior staff just hiding behind the computer typing notes, because they don't really learn anything that way, and you don't learn how to be a doctor and how to manage triage and respond to a sick patient. It's good to allow them to develop their own skills and some autonomy in that regard, because otherwise all you're really learning is how to type. You're not really learning how to practice medicine. So um, that was always my approach to Met calls, was trying to involve everyone and get them hands-on involved in the leading a Met call response. Some might say I'm too harsh.
No, it needs to be done. It needs to be done. I guess going back just one step further, Michael, going back to med school and sort of what got you into all this at the start. I mean, was there sort of one thing that sort of led you to it, or I don't know, do you have any like medical influences in the family, or anyone who said, or maybe you saw like a TV show or something and you're like, oh, this is me, like I've got to do
Do
this.
you mean about getting into medicine in general?
Correct, yeah. Yeah.
As a child, I didn't ever think I was going to be a doctor. Originally, I always thought I was going to be a civil planner or civil engineer. I used to like the maps and malways and car games and things, and like the idea of planning cities. And in an alternate dimension, I'm sure that would be my job. I used to like games like Sim City, and there was another one called Cities Excel. There was a few in that series I really enjoyed. When I was 15 years old, I had a very unusual illness. I had something called spontaneous pneumothorax, which is like a collapsed lung. It tends to occur in tall people. And I had to have a procedure called a pleurodesis to stick the lung back up, essentially. And I spent 14 days in hospital as a teenager, which was not a lot of teenagers spend a lot of time in hospital. And that was sort of the first time I'd ever been sick and had exposure to medicine. I think that that was one of the lures long term into pursuing this career trajectory, was seeing all the great nurses and doctors at the Royal Children's Hospital, what they did every day, the life saving interventions that they did, the way they spoke to families, the tremendous care they give. And I think that was the first time that I was interested in something sciencey. Otherwise, before that, I always thought I was going to be actually in the engineering realm. And then from then on, I sort of changed the sort of books I read. I tended to read more about basic anatomy books for leisure, and even some things about zoology, birds, and biological science. And then, sort of by the time I was in year 11 and 12, I was more set on the biomedical field pathway and then medicine. So, possibly if I didn't have a collapsed lung and I was breathing fine, I'd be solving traffic problems in a government office somewhere. Like, it could be a completely different discussion that we're having today, and discussing about EV cars versus diesel or something. But yeah, funny how life sometimes gives you a curveball but changes your whole outlook and trajectory.
You'd be a Sherlock Holmes in a slightly different area of life.
It'll be something like roundabouts are better than traffic lights.
Are roundabouts better than traffic lights?
They are. They are if the traffic is equal, I believe, at all entry points into the roundabout. But if you have one dominant entry point to a roundabout, the system fails. So there's like a critical point where a roundabout capitulates. Similar to the Frank Starling curve of cardiology, there's a point of resistance where if one lane is overpowers the roundabout, you decompensate and the system fails. Sorry, that's a good. That would be me in the alternate dimension, is roundabouts. So yeah, funny how life works, and yeah, I didn't want to be a doctor when I was a kid, so it happened all later.
Yeah, it's interesting how it all pans out. I guess the final question, I mean, you're in infectious disease, where you probably see a bunch of surgical interns, surgical resis, probably surgical registrars are the biggest culprits, contributing to superbugs. With overprescribing of antibiotics and everything. What's your If you just had to have simple rules of thumb or any advice for any junior doctor sort of navigating this antimicrobial world, in terms of which antibiotics and how best practice, are there any simple things you keep coming back to that maybe a lot of junior doctors miss or keep getting wrong? I'm sure you have a lot of discussions with the residents on different wards what to do.
Hmm. Most hospitals will have their own sepsis pathway and guideline document, which will have like what the hospital suggests based on local microbiological data should be your approach to a certain infectious syndrome. So if someone comes in with pneumonia, based on the severity, you should use these antibiotics. The same as for abdominal infection or CNS. And being familiar with the hospital infection guideline is one that I would suggest. And then the other one is called Therapeutic Guidelines in Australia, or ETG, and that just gives a uh, good guidance of empirical treatment of an infection that you come across. In terms of some key points for junior doctors, there's a lot of temptation to escalate antibiotics, and this view that broader the better. because it makes you feel a bit more confident that you're covering the bug. But it's actually not good practice, not just from an antimicrobial stewardship perspective about superbugs, but generally, the broader the antibiotic, the less effective it works. It might kill more bacteria, but it does it poorer, slower, and less effectively. Whereas, for example, for Staph aureus, flucloxacillin cefazolin kills it very quick. Tazocin kills it, but kills it poorly. And often it's like, oh, they're a bit sick and have had a fever. We need to change them to Tazocin. You're actually worsening the outcome. You're going broader but weaker in the sense that the bug that you're trying to target in someone who had staph in their blood is actually getting an inferior treatment, even if the junior doctor probably can sleep easier at night thinking, oh, they're on Pip-Taz now, fantastic. So you need to think about the syndrome that you're treating and what the best treatment is for that. That's what I find a lot of doctors sort of misconstrue, and that you see the big guns like meropenem brought up, but the reason we don't use them up front is often they work slower and less effective than some of the narrow spectrum agents. Even for like plastics doctors out there who are managing group A strep infection, penicillin is the best treatment. Works the fastest, works the quickest, best targeted for group A strep. If you start using pip-tazes and meropenem, it doesn't work as good. You're just, yeah, they're going to stay septic for longer. You're just going to give them C. diff, and you're just going to increase the amount of multi-resistant organisms in the future. So sepsis pathway documents are actually your friend. And the reason we recommend certain antibiotics and is because they often are the best ones. So that would be something I would suggest to junior doctors out there. Read their documents.
That's fabulous advice, because I think a lot of people, as you said, they get scared. They think, oh, the stronger antibiotic. They often use that word, the stronger antibiotic, and they like pull out like a shotgun and say, because it very much is like a shotgun. Like you can't see it, so you're splattering all everywhere, so you might get a hit, rather than pulling out the sniper rifle and actually targeting, the bug.
The shotgun's always messy. You need the rifle. That's the truth. You need the shotgun antibiotics when someone comes into emergency department critically ill and you don't know what they've got. But if you've got someone who's got a positive blood culture and you know what they have, just treat that. It's very rare for someone to have like staph infection. So you've got blood cultures positive for staph aureus, but then we want to add something else to treat their UTI. It's like, do they really also have a UTI? Probably not. It's all staph. So the temptation to use the shotgun should be avoided where possible. Use the rifle and be as narrow spectrum as possible for the best outcome for the patient.
Yeah. Well, pretty strict gun laws in the hospital. Keep the meropenems, the linezolids, everything under wraps, and then save it for when you don't know what's going on.
We have a word for this in medicine. In gun law, it's called an arsenal for the amount of weapons you have. In medicine, we use a word called armamentarium, but it doesn't come up very often. But remember that word, armamentarium of drugs.
I like it. I like it. I think the interview question for infectious disease would be to spell that word.
It's a mouthful, but it's a good word. All the drugs at your disposal is an armamentarium. So that's the word of the day.
God, all right. I love it. I love it. Michael, we might just wrap up things there. Thanks very much. It's been super interesting chat, and I've been waiting to get you on for a while. So very much appreciate it.
No worries, Harry. Happy to chat anytime. Glad to have contributed.
All right, so that's the end of that conversation. If you want to be part of something like this, you think you have an interesting story in medicine to share, maybe it's how you got in, and maybe it's that you got on a different training program or you went through some adversity, that's something that you think you'd be interested in doing, then send me a message.
The link will be in the description how you can get in touch. If you know someone else that's probably keen to share their story, or you think that they would be a great person to share on this, then definitely link them in and we can get them on. If you want to stick around, there's plenty of other videos on here to check out and keep you informed, keep you interested, and keep you learning more about medicine. So there you go. Otherwise, we'll see you next time. Bye.